Hey guys, Vince, one of the first years. All right, today I'm doing clinical pearls. Special shout out to the clinical pearls teams, Dr. Delgado, Pandya, and Raber. So we'll start with the case. We have a 23-year-old woman, no past medical history, belly pain, scant vaginal discharge for 6 days. It's right-sided, constant achy. Tylenol helps a little bit. Discharge is yellow, green, doesn't smell. Multiple male sexual partners in the past. Last sexual activity 10 days ago. Her birth control is via the pull-out method. LMP was 2 weeks ago, a little heavier than usual. This is her review of systems. She had fevers, nausea, some vomiting. All right, so physical exam, vitals. She's a little febrile, borderline tachycardic, otherwise fine. Her cardiovascular exam's fine. Lungs are clear. Belly exam, diffuse tenderness palpation. Right is greater than left, and she's got voluntary guarding, but no CVA tenderness, and it's soft, non-distended. GU exam, she's got right adnexal tenderness palpation, CMT tenderness, green discharge draining from a closed os and a friable cervix. Because you are an intern who just completed their GYN sono rotation, you decide to do an EFAS while you're in there, which is negative for free fluid. And so now you get some blood work. So first off, HCG is negative. And then you try to get a wet prep, obviously. County does not have them. GC swab is sent. You're not going to get it for a couple days. CBC shows very baby white count. Otherwise, H&H is normal. Electrolytes are normal. Creatinine's normal. UA is normal. So you get some imaging. Abdomen pelvis. You have a thick, uniform enhancing abscess wall that is multilocular with increased fluid density in the right adnexa. You get a transvaginal ultrasound after about 10 hours of waiting, and it shows a complex thick-walled multilocular cystic conlection, internal echoes in the right adnexa. So the labs are non-specific. Imaging is consistent with, any guesses? Yeah, TOA. So today we are going to be talking about PID. All right, so these are learning points. So how does PID present? How do we evaluate for PID? How do we manage PID? First thing we got to talk about is, what is PID? So it's an upper genital tract infection. So it involves the uterus, fallopian tubes, ovaries. And in women, that's typically caused by spread from the lower genital tract via sexually transmitted disease. Very rarely can be non-sexually transmitted, such as but not limited to surgery or instrumentation. This includes a recent IUD placement. Most common serious infection in sexually active women ages 16 to 25. Most common pathogens typically include gonorrhea, chlamydia, Mycoplasma genitalium. On rare occasions, it can be TB, H. influenza, strep pneumo, and actinomyces. However, most often, it's a mixed polymicrobial infection. So how does it present? Typically have a young woman under the age of 25, history of STIs, chlamydia is the most common one, treated or untreated, IUD placement less than 3 weeks out, lower belly pain, pelvic pain, vaginal discharge, postcoital bleeding, urinary complaints, fever, malaise, nausea, vomiting. So how do we evaluate for PID? So first, you gotta do a pelvic, right? You gotta do a thorough physical exam. Make sure they don't have adnexal tenderness palpation, which is actually the most sensitive finding. CMT, mucopurulent cervicitis, which our patient did have. If patient has right upper quadrant pain plus or minus jaundice, you want to start to get worried for Fitzhugh-Curtis, right, which is actually a pretty late finding. While you're doing the pelvic, you want to get GC swab, right? Don't forget that. Otherwise, you got to make the patient swab themselves, and it's a little awkward. If your institution has a wet mount, you can get a wet mount, check for anything on there. If the patient looks sick, if they're toxic appearing, if you're worried about a more systemic infection, you might want to get some blood work, right? So check for a white count. You can send inflammatory markers, although a lot of people will argue they're pretty non-specific. If they're really sick, you might want to get high 5 RPR. Always get a urine. Make sure they're not pregnant. Make sure they're not having a UTI. send a culture if you feel like they've had multiple UTIs in the past. And then if they do look really ill, if they're very febrile, they're nauseous, they're vomiting, if you're worried about a TOA, you want to rule out other alternatives. They can't tolerate PO, they're pregnant, if they can't tolerate any PO medications, or you don't think that they're going to adhere to medication therapy, you're going to want to get imaging, right? So what do we normally get? You get a transvaginal. If you're really concerned about something intra-abdominal like API, cholecystitis, anything else, what do? Send them to Donut of Truth, right? So these are this is part of the CDC Empiric Diagnosis criteria. You can kind of read through them. They're purposefully vague. The reason being is because the risk to not treating someone for PID and having them have long-term complications such as infertility and increased risk of ectopic is really not worth it when you can just treat them either outpatient or just start the therapy while they're still in the ED and then send everything else to the pharmacy. So like I said earlier, one of the most sensitive test findings is usually adnexal tenderness. So if they have any type of tenderness down there, you want to really consider having PID on your differential. Here's the additional criteria. So if they're febrile, if they have mucopurulent discharge, if they have a lot of white blood cells on the wet mount, or if they have a documented GC infection, right? If they have elevated inflammatory markers, I mean, it's pretty non-specific, like I said earlier. So here's a CAT scan. This is showing a right-sided TOA with a pyosalpinx. Typically on CAT scan, you're going to see like high attenuation fluid, pelvic masses, which can contain fluid levels, or gas, thick enhancing abscess wall. Tubular or multilocular configuration is more consistent with pyosalpinx, such as this. Here, what we see is actually subscapular liver hyperdensity, which is consistent with Fitzhugh-Curtis. Okay, this is a little bit more subtle, and again, this is more of a late finding. If you get a transvaginal, this is what it might look like if they have a TOA. So typically on ultrasound, you'll see multilocular complex retrouterine or adnexal mass. You might see debris, septations, or irregular thick walls, as well as echogenic debris within the pelvis. Here's just another view. And so how do we manage PID, right? Now that we have a high suspicion for it, we want to treat the patient for it, right? So one of the biggest mainstays of treatment is telling them to abstain from sex, right? It's kind of a no-brainer, but you want to tell them, be very explicit, no sex until therapy is fully complete, not just for them, but also their partner or partners who they've been recently sexually active with. Symptoms have to also fully resolve, okay? And so to actually treat it, right, we got to give antibiotics, but the decision on which antibiotics to give is going to be based on whether or not you're going to be, number one, admitting the patient, or number two, discharging them, right? And so if you're considering to figure out how to, admit or discharge, you want to figure out, number one, are they stable or are they unstable? If they have a massive TOA, if it's greater than like 9 centimeters, the postmenopausal, if they're for whatever reason unstable, you're going to admit them. If they're pregnant, you're going to admit them. Septic, admit them, right? Otherwise, you can discharge them. You can start them on antibiotics while they're in the ED, and then you can discharge them. Basically, what you want to give them is Flagyl, and then treat them for whatever organism you think they have. Most importantly, cover them for gonorrhea, chlamydia, right? So most commonly what this ends up looking like is you give them ceftriaxone, doxy, Flagyl. If they're going to stay inpatient, then you can do the same thing, but IV formulation, or you could do like Clinda and gentamicin, or Unison and doxy. But basically, you want to cover those most common sexually transmitted diseases. So closing points, consider PID in sexually active young women with adnexal uterine tenderness palpation, or CMT. Make sure you get, at the very least, urine, plus or minus labs if they look sick. Definitely get imaging if they look sick. What you want to treat with is, the CDC recommends you always give Flagyl, to cover your gram negs, and then treat most commonly gonorrhea, chlamydia. And then for your dispo, just admit them if they're complicated, they're pregnant, they look septic, you don't think they're going to tolerate outpatient therapy, or they return because they failed outpatient therapy. Just admit. Any questions? Okay, thank you.